Hey chiropractors, Dr. Charlie here with ProCredits. We see a lot of hypertonic muscles causing pain in our office. Many times, treating this hypertonic muscle will only lead to more joint instability because the hypertonicity of that muscle is due to an inhibited muscle in the area. Muscle testing is a great way to find and treat those inhibited muscles because once we bring those inhibited muscles into facilitation, the hypertonic muscle associated will just melt away. ProCredits offers 2 great modules on muscle testing at ProCreditsCE.com. Here's an excerpt from one of those modules. Enjoy. We will now discuss the different treatment methods on how to fix the inhibited muscle. In order to do that, we must better understand the muscle spindle and the Golgi tendon organ. Muscle spindles are found in the muscle belly, and they react to the muscle being overly stretched. When a muscle is stretched beyond a safe distance, the muscle spindle will fire off and send an afferent signal to the posterior horn of the cord, which will then synapse at that level and cause a reflex of an efferent signal to go back out to the muscle, telling that muscle to contract. This is a simple muscle stretch reflex arc. The stretch of the muscle spindle causes the reflex contraction. The Golgi tendon organ is found at the origin and insertion of the muscles in the tendon. When the muscle is overly contracted, the Golgi tendon organ will send a signal to the posterior horn of the cord, which will then synapse with an inhibitory neuron, which will send an inhibitory signal back out to the muscle, telling the muscle to relax. This is a simple inverse stretch reflex arc. The stretch of the Golgi tendon organ causes reflex inhibition or relaxation. Both the muscle spindle and the Golgi tendon organ act as a protective mechanism for the muscle and the joint. Using this in a treatment method, we see that muscle spindles will monitor the length of a muscle, which, if stretched, will cause facilitation of that muscle. If the muscle spindles are approximated, it will cause inhibition of the muscle. We can mechanically affect this by pulling the neuromusculospindle cells apart. This will increase the tension in the muscle, as the muscle will think that it's being stretched. If we approximate or press the neuromuscular spindle cells together, this will decrease the tension in the muscle, as the muscle spindles will think that they are being approximated. Using these 2 methods, we can effectively cause the muscles to either be facilitated or inhibited at that muscle level. The Golgi tendons, on the other hand, are found in the muscular-tendinous junctions at the origin and insertion sites of the muscle. They monitor the tension in the muscle, which, if strong enough, such as a strong contraction, will turn the alpha motor neurons off, thereby inhibiting the muscle. The muscle starts out strong and then during strong contraction becomes completely weak. This is a protective mechanism for overcontraction. If you ever noticed an arm wrestling competition in which the loser loses suddenly and loses all strength in one quick motion, this is because the tension on their bicep was so great because of such a strong contraction that the Golgi tendons fired off and caused inhibiting of the muscle. If we push the Golgi tendon organs of the muscle toward the belly several times, this will facilitate the muscle. If we pull the Golgi tendon away from the muscle belly, this will cause inhibition of the muscle. The next technique we will look at is the origin insertion technique. This is probably the most widely used technique in order to cause facilitation of an inhibited muscle. Prior trauma causes the tendon of the muscle to partially tear away from the periosteum on the bones, causing little lumps called microavulsions, which may cause inhibition of that muscle. Vibrotactile stimulation or massage of about 100 Hz on the microavulsions will cause the tendon to be pushed down upon the periosteum on which it is attached and facilitate the muscle. It has been demonstrated on NCV EMG studies that the alpha motor neuron is facilitated by vibrotactile stimulation as indicated by increase of the F wave, which is an antidromic volley that excites the alpha motor neurons following peripheral nerve stimulation. When the alpha motor neurons are facilitated, they send more nerve impulses per second to the muscle, giving it a greater force of contraction. This is the basis of origin insertion technique. Indications for the origin insertion technique will include a weak testing muscle with a history of trauma and/or small palpable lumps where the muscle's tendons attaches to the bone. This weak testing muscle will test strong when these lumps or the origin and/or insertion points are therapy localized. Meaning, you will test a muscle. If that muscle is inhibited or weak, you will have the patient place their fingers on either the origin or insertion point of that muscle, and then you will retest. If this muscle now tests strong or is facilitated with the patients placing their hand on the origin insertion points, then this muscle is a good indication for the origin insertion technique. A heavy massage or vibrotactile stimulation on the origin and/or insertion of the muscle for approximately 20 to 30 seconds will facilitate the muscle and should now be strong on the follow-up muscle test. Next, we will discuss reactive muscles. When contraction of one muscle causes the subsequent weakening of another muscle, these are known as reactive muscle pairs. The contracted muscle we'll call the primary muscle, and the muscle that became weak is known as the reactive muscle. This is due to improper mechanoreceptor communication between the two muscles. The two muscles associated may be synergists to each other, antagonists to each other, or even gait interlinks, meaning muscles that are reacted or contracted during the gait process. This could be, for example, the biceps of the right arm and the hamstrings of the left leg. Both of these muscles are being used during the gait cycle. Triano and Davis demonstrated reactive muscle pairs of the rhomboid and deltoid using electromyography. When contracted separately, the rhomboid and the deltoid muscles both had electrical activity. However, once the rhomboid was contracted, the electrical activity of the deltoid began to decrease. This means the rhomboid was the primary muscle, and the deltoid, which became weak, was the reactive muscle. Because reactive muscles may test facilitated or strong in the clear, they may be overlooked. Therefore, in order to determine where to begin testing for reactive muscle pairs, we need to understand that primary muscles may have undergone some sort of injury, such as sudden stretch, overcontraction, direct trauma, or if it has been held in a contracted state for a long period of time, or a repetitive motion was performed. Using a good patient history as well as identifying tight, tense muscles and pain patterns can give us the clues as to which muscles we should begin with for functional muscle testing. These are found common in many athletic re-injuries when there is no apparent reason for joint strain. Spindle cell of the primary muscle is set too high, so when contracted, it's causing the inhibition of the reactive muscle. Treatment is to turn down the overpowering muscle's mechanoreceptors, i.e., approximate those spindles together. We see reactive muscles in many athletes, especially where no cause of their injury can be found. Consider a baseball pitcher. When throwing a ball, the anterior deltoid and pec major are prime movers, but in preparation for throwing, the rhomboid muscles contract to pull the arm back and stretch the anterior deltoid and pec major. As contraction of the rhomboid becomes complete, reciprocal facilitation of the anterior deltoid and pec major occurs, which gives them full power. However, if the anterior deltoid and pec major are reactive to the rhomboids, then reaching back and contracting the rhomboids will result in inhibition of the anterior deltoid and pec major, just when they are needed most. Diagnosis of this would be if after a full contraction of the rhomboids, the anterior deltoid and pec major tested weak. Then you would treat the rhomboids by approximating the muscle spindles several times and then retest. You would repeat until the reactive muscle tests strong. So in conclusion, reactive muscle pairs are when the first muscle or primary muscle, which is the muscle that is contracted, inhibits the second muscle or the reactive muscle. The treatment would be to turn down the muscle spindle cells of the first muscle or primary muscle. We can accomplish this by approximating the muscle spindle cells together and then retesting. Some examples of reactive muscle pairs are the following. Please note this list is not conclusive and there may be other muscle pairs that you can find on your own. Remember, looking for muscles that are hypertonic or muscles that have been injured or muscles that have been held in a contracted state or have been overused may be the primary muscles. These examples could be the rhomboid or pec minor muscle being the primary muscle, causing the deltoid muscle to be inhibited. The contralateral SCM muscle, causing the psoas muscle to be inhibited. The upper trapezius or contralateral hamstring muscle, causing the lat muscle to be inhibited. The quadriceps muscle, when contracted, causing the rectus abdominis or the hamstring muscle to be inhibited. The sartorius muscle, when contracted, causing the tibialis anterior muscle to be inhibited. And finally, the TFL or psoas muscle, when contracted, may cause the adductor muscles to be inhibited. Remember, reactive muscle pairs could be synergists, antagonists, or muscles involved in gait interlinking.